So today I'm super excited to be speaking with Professor Harrison Chow. You're a clinical associate professor in the Department of Anesthesiology at Stanford. Is that right, Harrison?
Yes, that's correct.
Yes. Well, yeah, I know some other people in that department, and I think some people who watch these recordings will be familiar with the work of Boris Heifetz, and you're associated with his group as well in some of the research you're doing.
Yes, I'm normally in his lab.
Right.
He's my director boss, and so everything goes to him.
Awesome. I think your work sort of caught our attention because it's fairly unusual. It's extremely interesting, I think, in terms of potential practical applications down the track. But I was wondering if you could explain in a few words sort of exactly what you're working on at the moment and recent publications and case series that you've reported on.
Oh, just a slight background that the observation of dreaming has occurred when I was in private practice in the Los Gatos area for a long period of time. I was there for 16 years, and then I had an opportunity to come to Stanford and work with board and really kind of attach the scientific lens to an observation of dreaming that seemed to be associated with the anesthesia, and it seemed to be induced. Since I've come to Stanford, we've been able to, with protocols in place, using IRB structure, and most spectacularly having an EEG, which I did not have largely in practice, we were able to not only start generating observation of anesthesia dreaming, but seem to identify a signature that we could identify so that we got to a predicted place.
Mm.
Mm.
So I think most people will be familiar with the sort of concept of dreaming, at least in a non-technical sense, but could you describe in a few words what anesthesia dreaming is?
Oh, the anesthesia dreaming is the specific psychological description is something that a patient will describe as psychological activity that is involving acute memory and visual images. So this was published as kind of like snippets of memories by Kate Leslie in 2007. She had a landmark paper about dreaming and this kind of psychological phenomena of visual images and almost a first person kind of engagement in those images was occurring about 22% of time. And
Mm.
what I was noticing out of practice is that with kind of sedation, kind of slow, kind of pre-emergence sedation, with patients with regional blocks, we were getting these reported visual images and these experiences more like 50% of the time.
Mhm.
And then, most importantly, though, there seemed to be a structure to uh, these images and experiences that patients reporting amongst emergence from anesthesia.
Mm.
Those were specifically, they were describing memory-based imagery and seeming like anxiety resolution regarding things that were disturbing them during pre-surgery, basically. So
Right.
if a person was agitated about the sale of their car, they would dream they were in their car. If a patient was agitated, these are some very, very common things, right? You really does it's bad. If a patient was, this is an extremely common dream
Mm.
in particular was as his mother's having surgery who would dream that they had to pick up their kids to school or drop off their kids to school. So that was that I just started to notice this pattern that when people were reporting dreams, they seemed to be fulfilling some kind of anxiety that they're carrying into them into surgery.
But
So
maybe to really highlight this, I guess the interesting thing here is that probably for most people, myself included, until I came across this research, you typically think about anesthesia as a state of unconsciousness, but really there's almost like a sort of periconsciousness here or an altered consciousness state where emergent dreamlike phenomenon can occur. Maybe to highlight this, I was reading this interesting case report, one of your case reports from a few years ago, about a woman who suffered a knife attack right to her hand and had actually had post-traumatic stress disorder from that attack, had this sort of anesthetic dreaming going on during the procedure, but it was actually therapeutic in that case, as described in the case report. So
so that
that sort of
became
example.
so I'm here at Stanford, and again we're carrying this pattern of people carrying their anxieties, and we had this young woman. He was 27. Just randomly had picked up this case, but I was already observing a lots of dreaming, and again with the EEG kind of monitoring pre-emergence, starting to identify what that pre-emergent signal looked like. And he seemed really withdrawn, very, very anxious. Really, the end of the day surgery. And we did sedation for her through the case. We had an EEG. It was a pretty long case about reattaching her feet, reattaching the tendons that had been cut from
Mm.
this knife attack. She reported immediately coming out of anesthesia, she had a dream. Initially, it was a little disturbing because she dreamt that she had through the knife attack again. This was over a family dispute, her sister-in-law, and that she had come to the emergency room and she had been aware of getting her hands repaired in surgery. And so this was very alarming initially
So
to us.
this, just to be clear, this is the dream she is having
This
under
is the
the
dream
effects
she's
of
having.
anesthesia, that reliving
Yes,
the whole experience, including the
reliving the
surgery.
whole experience, right? So that, and we're having this told to us in the OR, and the surgeon is really Dr. Yao. It just gives me a really dirty look, like this is really bad anesthesia. And then you can imagine. So this is already describing why lots of anesthesiologists don't like to go into the zone, right? And then she says, and then I went home and I was cooking and my hand was fixed. So then the surgeon looks at me, yeah, not such a bad job, right? But so then he was noticeably different and recovery. The person that I saw pre-anesthesia kind of had this body language as I described, very anxious, really hunkered down, unwilling to talk, just reserved. And then we had a patient recovery, was happy, just looking at her hand and just, her hand was in all these dressings and everything, but she was smiling and she's talking about this dream. And it's just like, hand is fixed. And so I texted Boris. I said, hey, let's look at this case. And so she was interviewed by Boris operatively, and she'd been discharged. And she was interviewed by trauma psychiatrist Laura Hack. She does a lot of work at the Palo Alto VA. She applied all these anxiety and PTSD scales. And, this is kind of that wish fulfillment pattern that you see from the mother trying to get her child to school, which literally there are hundreds of those. And then you have this version that is, well, in this case, and is fixed and it's functioning. And so she was followed for a 1 week period and a 1 month period and a 1 year period. And she no longer met criteria for post-traumatic stress disorder. By the way, I've followed up with this patient. Now we're about 3 years out. She still does not have post-traumatic stress disorder. And like I said, what's really odd talking to her, especially in recovery, was how disassociated she was from her injury. Like to talk to her about, 6 months ago. Because she's like talking about somebody in the third person. Like the injury
So,
didn't occur to her. And so that's what we put on the case report. We were really pleased that they would publish it. That was the first of them. And then we've had a couple more. And
yeah,
so we,
you can certainly find a lot sort of online now. There's many of these case reports from other places as well. So you're claiming here that maybe 30 to 50% of people have some kind of anesthesia dreaming. I can imagine it being very much underreported because it's not typically something that's going to come up in sort of, post-surgical evaluation. In how many cases would you say these sort of experiences are therapeutic, and across what sort of other indications, perhaps?
so that's getting down to, kind of what our mechanisms is. So I think that myself at Stanford, I've done roughly 1,200 gene surveys. Across our entire
Right.
team, we've done about 2,000 gene surveys. Of that, roughly 60% are reporting dreaming. So we're all doing kind of this pre-emergent technique. And so we get a roughly about 65%
Mm.
dream recall rate. And that's across all providers that I know.
Right. I
And
could see skeptics saying this is, this is, to use your sort of phrasing, this is just bad anesthesia. How can you be sure this is, I mean, with that many cases, presumably it can't all be bad anesthetic method. So, what distinguishes the
what
seizure dreams from true anesthesia?
well, Sam, you kind of pointed to it. That's if I said that we did 2,000 anesthetics, and let's say we've worked with 100 surgeons on these, we have remarkably had no pushback, no complaints from patients or
Yeah.
surgeons.
Yeah.
The reason being is that they are all waking up like the patient with the hand trauma or the patients that were worried about not taking Johnny to school. They are waking up. They have quick emergence from anesthesia. They seem to have a remarkably low postoperative nausea rate. They have no OR recall. The knife attack patient is probably the closest I got to that. So they are coming to clinic with surgeons in a remarkably chilled out mood about their disease. So we see this as a procedure, just we're talking within surgical anesthesia, which seems to have a positive effect on the recovery of the patient immediately. Seems to, in terms of like postoperative nausea, postoperative sedation, seems to reduce perioperative anxiety, is regarding their surgical care. And then patients that I've seen or talked to have done this multiple times because they come back for repeat surgery. They almost always want to go on this ride again. So that's and
A vote of endorsement then perhaps, if it was particularly aversive after the surgery, then a lot of people wouldn't find it retrospectively so
yes,
helpful.
yes, and the surgeons because this involved a little bit of like more time from anesthesia, just like a couple more minutes or 5 minutes. And surgeons are very time sensitive about the OR period, but the kind of results reinforce themselves. The patients are doing better. So whether they're tolerating what we're doing within surgery or they're the surgeons, but I think that we would have gotten some negative feedback or a negative blowback from the surgical community. And honestly, Samuel, I've been doing this for 15 years now. There's just everybody's super receptive to it
Right.
because in the shortage, you got happy patients.
Mm.
Happy patients, they seem to be more apt to comply with their surgical care and from everywhere from every point from the patient to the surgeon, the recovery room,
Mm.
it has been a pleasant experience. Now, how much of a pleasant experience? Well, that's the lab. We have to do this in a controlled setting. But in
Sure.
just in surgical anesthesia care, this seems to be very beneficial.
Can you think of one or two more examples? I mean, that's a very interesting kind of specific case where the PTSD is very much related to the surgical intervention that they're anticipating. Do you also see this? I could imagine things like perhaps tumor resection or something where there might be some, you know, other anxiety, end of life anxiety, maybe around a cancer diagnosis. Have you also seen sort of clear examples there?
So we were about 750 cases into this. So there's largely for myself, I've been focused on orthopedic surgery and breast cancer surgery. So I was using a methodology that I came up with the CRNA department that was using a propofol remifentanil. About 400 patients into the breast cancer surgery, which by the way, we were just getting lots and lots of, controlled dreaming. One of the CRNAs popped up and said, Dr. Chow, have you asked any of these patients whether they have breast cancer in their dreams? And, we're so focused on the action of all these dreams, right? Like children on time and, going to, being with their family in Europe or whatever. We just didn't ask that question. And so when we started asking these questions, they, lo and behold, and then it was true with the orthopedic dreams. We kind of just assumed this as well. Nobody dreams they're injured or sick. So of course, when you ask them, they're like, "Yeah, we don't." Well, it's really like, Chow, nobody has ever asked me that. No, I didn't have cancer in my dreams when I was in Europe with my family. Right. And then if you ask the ACL patients, the ski patients, it was like, of course not. I'm skiing where I had an accident and tore my ACL, except this time I'm healthy. I had the strangest dream this week, actually. We had a patient who dreamt she was her husband getting ready for ACL surgery, so anterior cruciate ligament surgery. And she's like, "Yeah, I was with my husband." I said, "Of course." And so this was, well, we can get to this a little later, but everybody dreams are basically being safe, right? And so I said, "Do your husband really makes you feel safe?" "Yeah, and I was at home and we're going through the checklist." I'm going to go have, I'm getting ready for knee surgery. And so I just felt so safe being with my husband getting ready for surgery. So this was her dream. I said, but you didn't have a knee injury. And she said, yeah, that's really odd. I'm getting ready for surgery, but my knee is fine. So you could see like the dream logic is different. It's a emotional safety based logic.
Mm.
So we see a lot of those. But the best one, I took care of this patient. So she's out on social media for this. So just so people know, Stanford Anesthesia has social media. They're putting out some of these patients. I don't know if you know about this, and it's on Twitter, and I think it's on LinkedIn. And so Kelsey Newman Lauder is a patient I've taken care of for 3 years. She's a teacher in Sacramento. She's had multiple dreams over four different anesthetics. So I didn't ask her whether she had cancer in her dreams till the third case, fourth surgery, which was about a year ago. She dreamt that she was not only didn't have breast cancer, not only her kids were fine. She was really, a lot of her dreams were focused on her children
Mm.
and her worries about her children if she had cancer. And each time she was doing a book tour about how she had defeated breast cancer. So this is
In the anesthesia
in the
dream
fourth
state.
dream, yeah, in the anesthesia dream, right?
Yeah,
And
fascinating.
so you can imagine. So Fred Durbis is the surgeon, and so this is all public information. I saw him, and he said, "Harrison, the difference between what she looked like 3 surgeries ago through the fourth surgery is just incredible. I mean, she has got advanced breast cancer, and here she is more chilled out than your average person at Starbucks. It's just about talking about her cancer. So we are now openly in our research calls calling this some kind of fear dissolution, fear, almost like
Mm.
a fear enzyme in terms of the neurological process.
Mm.
It just seems to dissolute the fear that's uh, that's prevalent. But whatever is most prevalent doesn't mean that all fears. It's just the fear, regarding what is going into under anesthesia. So
Mm. It seems like there's some parallels here to some of these sort of emerging treatment options like ketamine itself and psychedelics,
Mhm.
where people also report this sort of rapid dissolution of anxiety associated with a diagnosis. So obviously, I think I read somewhere that you're sort of viewing this as being potentially therapeutic. And the other thing that I saw that makes that really interesting is that it seems to be inducible. So I was wondering if you could
Yes,
maybe describe a little bit, which it sounds like is the focus of sort of your research at the moment, is how to show that this is actually therapeutic, which I could imagine being, using a control group who doesn't report any dream anesthesia and looking at their outcomes, as well as how it's inducible, because that opens up some pretty interesting possibilities.
yes. So within surgery, we don't have an IRB yet where we can induce anxiety. So I can't like get into discussion with a patient about, for example, tell me about your knife attack, or I can't induce the anxiety. But in the lab situation, we can. So we basically have four different anesthetic we know that can induce dream anesthesia. So propofol is one, ketamine is one, dexmedetomidine is one, and surprisingly, sevoflurane is another one. And all of those, clearly, sevoflurane is the most located, but in my mind, probably the most powerful version of it because it's a gas. So the one in the lab is using the protocol that we developed with the breast cancer and the orthopedic patients, which is a deep form of anesthesia that you see that, of course, allows surgery to occur, but also creates a distinct pre-emergence pattern during the lightening of anesthesia. And so this is a specific the beta alpha. I'm sorry, getting into a little technology here, but it's going from very sluggish kind of waves, EEG waves, to very fast, high frequency waves, and a certain mixture of kind of a beta alpha signature
Mhm.
that we can see. So, in
And just
particular,
quickly across drug classes, you're saying this is typically in the emergence phase of these anesthetic states?
correct. Yeah. So this is the part where anesthesiologists, it no longer has really good surgical relevance. This is a level of anesthesia where the patient can be shaken awake.
Right. Right.
And so that's the best way to describe it. They
I've
won't
been in that
respond to their
state.
name.
I've been in that
You've been
state
in
several
that
times
state.
from surgeries.
Yes,
I know the phase you're talking about. Yeah.
yes, yes. You can be shaken awake, but you won't respond to your name.
Right.
Why that's significant is that literally you can't do physically noxious stimuli. You can't do surgery during that period of
Yeah.
time. So the trick here is that you hold that patient into that place. So then we would titrate in the lab the anesthesia to maintain this kind of beta alpha high frequency EEG pattern and then have the
Right.
patient in that state.
So it's the EEG that allows this to be inducible by titration of additional anesthetic.
That's
That
right.
that makes
Yes.
sense. Okay. I
Yes.
get it.
Yes. So instead of titrating anesthesia to allow surgery to occur, or titrating anesthesia so that there are no, spinal cord reflexes or cranial nerve reflexes causing patient movement, or titrating anesthesia so the patient isn't breathing, brainstem repression. We're titrating the anesthesia. We believe to allow all the brain circuitry to achieve some level of independent neural functioning with the exception of the prefrontal cortex.
Right.
So, so in other words, we believe what's happening is that the limbic system is becoming completely active. So a lot of the classic dream machinery, right there, the thalamus, the hippocampus, the amygdala are all becoming active, and our cortex is active, but it doesn't have any regulatory control.
Right.
We see a lot of occipital cortex activity, so a lot of visual cortex activity with a patient that is technically under anesthesia. So, in short, what we're having is all these different circuits, we believe, coming back online, very much like you would do anesthesia. We're turning on all your switches as we're turning down anesthesia. So, you have your spinal cord reflexes, your brainstem active, sympathetic system working properly. And we believe what's hidden in there is the limbic system activity also is returning. What does that mean? That means that you're having anesthesia dream where you get really brilliant colors, high definition. So you'll see some of the patients describe their loved ones. So some of this is on social media. They're seeing lost loved ones in more clarity than in real life. So we're living a version of a muddy life where we have lots of inputs, and somehow in this kind of anesthesia dream state, things are in high definition with a lot more colors. Uh, Again, I don't know. I need to do this myself. They do take volunteers at the lab, by the way.
I might have
If
to
there,
sign up. I'm very curious
you
about
might
this
have
sort
to
of
sign
altered
up. There
states
have
of
been there
consciousness.
have been some faculties who've signed up for.
Yeah. Yeah.
Yeah, but the initial volunteers, by the way, Stanford Psychology just emptied out all their grad students. They all signed up for this.
Yeah.
Which just kind of raised a lot of eyebrows. But anyway,
Sounds a
so
lot more interesting than some other studies I've
yeah,
participated in to help various researchers for sure.
so yeah, that's what we think is happening.
So is your sort of position here that potentially this is a phenomenon that seems like it might have some therapeutic relevance. It's been discovered through surgical intervention, but as you're
Yes.
describing here with the EEG monitoring and induction and sort of titration of
Hmm.
anesthesia, you could view this almost as being a sort of standalone treatment for different things potentially in
Yes.
future.
So this is why we're all jumping up and down right now. It's been a long process, but the anesthesia lab, it's called the IDEA lab, they went through a series of dosing trials. Now we have already undergone a randomized controlled trials with some FDA guidance. So it's not an FDA trial, but it's under FDA guidance.
Right.
And we're doing the propofol version with the EEG markers and the titration. But instead of allowing this to random happen with a few minutes, we're inducing like 30 minutes signature. And the patients, in the early part seem to be really responding. So I think we're very close to having a PTSD therapy here.
Super
Yeah.
interesting. Super interesting.
But that would be Pillar and Sika is our dream psychologist. fellow at Stanford. So we're probably the only anesthesia department that has a dream psychologist. A staff.
I did notice that on LinkedIn or maybe on your Stanford bio it was a chief dream engineer or something was one of the titles, which sounds like something metaphorical at a tech company for someone who's working on VR or something. But I like that here
No, this is
it's
this is
literally
really
dreams.
this is actually really an anesthesia dream. So I said chief anesthesia dream because that's what I do. I'm designing anesthesia dream protocols.
Yeah,
Yes, that's what
super
I do.
super fascinating.
But they're doing the propofol version, and that is the first version. And ketamine, I'm not involved with the propofol ketamine. You know, Boris, he's interested in propofol, psilocybin, right? So, right,
Yeah, well,
but it would all be based on getting into that signature, right? You get into that signature, so the medication creates that kind of anesthesia dream zone, and then the idea is then you would put other things to add some flavor to vanilla drinks.
right. Vanilla dreams. I like that. Well, yeah, this has been super fascinating. Where's the best place for people to go to find out more about the ongoing work at Stanford?
You could go to Stanford Anesthesia. They have a social media where they post updates on anesthesia dream research and other departments. But probably the best thing is source is Boris Heifetz lab. We have a giant publication. We don't have the proofs yet, but hopefully it'll come out and it's for anesthesiology and it looks at the methodology on inducing and identifying dreams in 474 patients. They're
Wow.
breast cancer patients. We're very proud of the work that I put into that. So it's been a couple of years, but hopefully that'll come out soon. And
You said that's in Anesthesiology, the journal?
yes,
Amazing. Well, yeah, thank you so much again for your time. Definitely one of the more interesting conversations I've had in recent memory. So, yeah, really
yes,
appreciate you making the time, Harrison.
thank you, Sam.
All right, thanks.